actually not actually put the manufacturers here because this is a CME course, and so I can't actually mention the manufacturers of these various testosterone assays. But shown here is what happens when you send a single sample. So the same sample is sent to over 1,000 labs around the United States, and they're asked to just measure testosterone level in that single sample from a hypogonadal man. And what you see here in the first row, if we take all over 1,000 manufacturers and a number of labs that measure testosterone, the value obtained in that single sample ranged from 45 to 365. Now, come on. That's extreme. That is unacceptable, right? I mean, I really do think that it's unacceptable to have that, and that's in large part due to the kind of assay that you have. For assay number D or assay D, the range of values from 65 to 200. On the other hand, assay H, not a whole lot of these because this is a mass spec assay, mass spectrometry based assay. The range is much tighter. So there's a lot more precision in terms of the actual accuracy of the test as well as the reproducibility of the test. The second thing is that because the assays vary in terms of the values they get, they also vary in terms of the reference range or the normal range that you get when you order a test and you see the normal range and you say, oh, it's low, it's normal. But the normal range varies considerably as well. Anywhere from a more traditional 298 to 1043 to something down to 132 to 813. So it can range the lower limit of normal, and the way a lot of clinicians define hypogonadism, I think, can vary considerably depending on the assay that you use. There's also extreme variability as a result, I think, because the way that laboratories have actually done quality control of their assays is based on reproducibility. So as long as you're reproducibly getting the same number using the same assay, you pass the quality control test. And as a result of that, you get all this different values for different assays and different assays with different normal ranges. What's missing really until more recently, and again, this is something that has been a trend over the last few years that I've been involved in, is to actually set up accuracy-based quality control. So not only do you reproducibly get the same number, which may be totally inaccurate, by the way, but you get an accurate number that reflects what's actually in the blood sample. Okay, and so accuracy-based quality control is extremely important, and the Partnership for Accurate Testing of Hormones that I co-chair with Hubert Vesper from the CDC have set up the assay hormone standardization program that actually has a gold standard to which assays could be compared, and in order to be certified by the CDC, you have to actually be within 6% accuracy of that gold standard. And so that's the best way to do it. This is not uncommon, okay? So for those of you who measure cholesterol, the CDC set up a program for cholesterol very similar to this testosterone program in order to standardize cholesterol measurements, because people were having the same problems with assays running differently with different assays. Values of cholesterol running differently with different assays. And so standardization was very important for clinical guidelines, for example, on cholesterol lowering medications. Same can be said for hemoglobin A1C, that we're all used to using a cut point of a certain value. If assays run differently depending on the assay of hemoglobin A1C, which is what's the case when they first came out, before standardization occurred, think of what chaos that might actually have with clinical guidelines that you have these days with A1C values, okay? So again, the goal for us is to try to standardize universally standardize and have accurate hormone values. Now, I'll tell you that we've made a lot of progress. All the major reference labs have been certified by the CDC. Where we have a problem, and for the administrators in the group and the people that are payers, Medicare and insurance companies, is that we still have assays that are manufactured that have a real problem with accuracy. And any manufacturers of assays have not caught on in terms of the actual adoption of CDC certification. So we have a lot of ways to go in terms of accuracy-based and standardization of hormone assays. Okay, as I alluded to at the beginning, testosterone levels bounce around a lot. And the major reason they bounce around is because of biological variability. And the major reason for biological variability is the day-to-day variability in testosterone levels. So a great example is when early studies were done let's say to register the testosterone gel, a single value, a testosterone level, was actually measured for enrollment into the study. And those individuals got into the study, but at baseline, when it was repeated, 30% of those individuals turned out not to have a low testosterone level. Okay, so in fact, they were misclassified as having low testosterone, and they went through trials, and they really weren't consistently low. And so those individuals were not hypogonadal, probably, or likely. As well, there's variability at the time of day, and so if you have to measure a testosterone level in the afternoon, it's lower than in the morning, as well as with fasting versus fed. Feeding either with food or with glucose actually suppresses testosterone levels. So as a result, I think you really have to, if you don't take anything else away, make sure that you repeat the value. That is something that we were taught anyway, regardless of whether we knew all of this, is to repeat a value that's low, and you should do it in the morning, fasting preferably, and not rely just on a single value. And even if you have two, if there's some equivocation, think about the symptoms, think about the non-specific nature of those symptoms, and actually rethink the diagnosis of hypogonadism if you need to. Lesson 3 is, I think, important, because what we have come to find out with these two major epidemics, in particular the opioid epidemic as well as the obesity epidemic, is that there are factors that deal with health that suppress testosterone levels and make look to the level, actually, that you could be hypogonadal. So there are functional, potentially reversible or treatable reasons why testosterone levels may be low, and hypogonadism may be actually treatable without testosterone. So the one thing I would like to emphasize is that there are two types of hypogonadism. There are causes of hypogonadism that I would classify as organic, and ones that are classified as functional. The organic causes are pretty straightforward. They're really destructive processes or congenital processes or structural problems in the hypothalamic pituitary gonadal axis that cause more or less permanent loss of function that need hormone replacement by and large, and it's usually more severe, both biochemically and clinically, hypogonadal individuals that present with organic causes. Most of the causes of testicular reasons for hypogonadism are organic. Some of the secondary causes, pituitary and hypothalamic problems that might cause hypogonadism, are organic. But the vast majority of individuals with secondary hypogonadism, in fact, will have what I classify as having functional hypogonadism. That is, they have a functional reason in an intact hypothalamic pituitary axis to have suppressed testosterone levels, gonadotropin levels as well as testosterone levels. So those individuals are very analogous to what we used to call functional amenorrhea in women. That is, exercising too much, having nutritional deficiency causes periods to go away, right? Functional secondary amenorrhea. A similar type of thing occurs in men because the hypothalamic pituitary axis, the reproductive axis, is very sensitive to the environment. It's sensitive to medications, it's sensitive to illness, it's sensitive to too much exercise, it's sensitive to weight, a variety of things that cause functional suppression. So if you think about the causes, again, we talked about the organic causes, well-known and more what we would call classical hypogonadism. But when you look at the organic causes relative to functional causes, you see on the list of things that can cause functional gonadotropin suppression and functional hypogonadism, things like opioids and obesity that can suppress LH and FSH and can cause low testosterone just because of that. And as a result of that, I think a perspective paper that I wrote and a review that I wrote really calls for really becoming a doc again, okay, and not just reaching for the hormone prescription or testosterone prescription pad and treat testosterone deficiency because it's low. Think about what the etiology is, if it's a functional etiology, if there's any of these things going on, maybe wait until the surgery they recovered from surgery, try to discontinue opioids or glucocorticoids, try to encourage weight loss and exercise. And in fact, what I would submit is this is a great opportunity to instruct patients that come in with low testosterone that maybe their low testosterone is likely due to the long-acting morphine sulfate that they're taking for chronic pain, or maybe it's because they're obese. And maybe that might be a good reason for trying to work on those types of things to reduce the opioids, to reduce the weight, and not really reach for testosterone prescriptions in order to treat the low testosterone, independent of what the underlying etiology is. So I think I would encourage a more holistic approach to management of these individuals. And that's been a major change, I think. I think early on when the low T syndrome came on board, everybody with low T was being treated because we weren't thinking about exactly, I don't think I was doing that, but maybe I was. But at any rate, it's just, we were reaching for testosterone because the testosterone levels were low without thinking of the etiology. And so think about the etiology. Lesson number 4, and we get into the testosterone trials here. And the lesson is that the pace of clinical research is slow. Okay, this is 40 years of experience in this area, but I would say the last 20 years, half of that time was in trying to understand trying to do a study of clinical outcomes in older men with low testosterone levels and hypogonadism for no apparent reason other than age. Okay, trying to do that kind of study has taken the last 20 years of my life. And so it's very much like a marathon. It's a marathon and not a sprint. And I think the tortoise and the hare really tells us really how to approach this kind of a problem from the perspective of a clinical researcher, is that you should just plot ahead, take your time, be persistent, and at the end, you'll probably get these things done. And I'll tell you a little bit about the results of the testosterone trials, which have been published in the last couple of years. One paper a year ago in the New England Journal, a couple in JAMA, and a couple in JAMA Internal Medicine in the last year, that will actually span the spectrum of short-term, underlying short-term clinical outcomes of testosterone treatment in older men. So I think it's helpful. I apologize, I talked 5 years ago on sort of the story of how the testosterone trials became or came to be. But I think for those of you who haven't heard the story, I think it's instructive in terms of clinical research or doing work in this area. So back in the turn of the century, in 2000 or so, we were all doing small studies in heterogeneous populations of men that either were relatively healthy, really were not sick at all, or that had various levels of testosterone that were low or even the low normal range. Small numbers, a large variability in the kinds of testosterone that were given, so that levels that were achieved were either too high or too low. Most of them were short-term studies, and most of them used non-validated and insensitive measures. So that's where we were back in 2000, about 20 years ago. And so in response to the need for more clinical outcome studies, Glenn Cunningham and I put together a proposal for the ESTEEM trial, which stands for the Efficacy and Safety of Testosterone in Elderly Men study, that we proposed as a result of a request for proposals from the NIH as well as the VA to do studies in this area of testosterone treatment in older men. Okay, so that's the reasoning we did that. And we put together we thought it was a very reasonable trial, although it cost quite a bit of money, of 6,000 men over the age of 65 with low testosterone exposed for 6 years to either testosterone or placebo, with the primary outcome being clinical fractures. At the time, there was bone mineral density data that testosterone increased bone mineral density, and so the clinical question of whether or not it improved or reduced fracture risk, I think, was a relevant question back then. It still is, by the way. But that's why it was chosen as the primary outcome. But we designed the study specifically to look at risk and long-term cardiovascular as well as longer-term cardiovascular as well as prostate cancer risk. And so the secondary outcomes had to do with that. And it was adequately powered to actually look at 30% increases in these outcomes. The budget was a little high. So $104 million was a little high. And so even though it was approved by both the VA, Cooperative Studies Executive Committee, as well as the NIH study section, and had a reverse site visit, 2 reverse site visits actually, it was actually approved, but because the budget was too high, there were insufficient funds. So for the clinical researchers in the audience that deal with multi-center trials, you go around and you shop it to other institutes at the NIH to see whether or not they could contribute some money. And in reality, NHLBI, the heart-lung, as well as the diabetes institutes were interested in contributing, but the National Cancer Institute was not. And so talk about bad timing. It just happened that the newly appointed director of the NCI, the National Cancer Institute, was a urologist who had prostate cancer, whose father died of prostate cancer, and who felt very strongly that testosterone trials were unethical at the time because of the risk of prostate cancer, even though there was no data to support that. So that's all that was needed for an approved study to not be funded. And what it generated was a Institute of Medicine, National Academies of Science Institute of Medicine committee to review all the area and to make recommendations about what to do about testosterone trials. So the Institute of Medicine met in 2004, and what they really recommended is what the testosterone trials eventually became. That is, they recommended short-term efficacy trials, not safety trials initially, before going on to longer-term outcome studies to determine the efficacy of testosterone, which they didn't think was established in older men with signs and symptoms of hypogonadism as well as consistently low testosterone levels, replaced to physiologic levels appropriate for younger men, and that these kinds of trials be coordinated into a single study with multiple coordinated trials, and the main outcomes being physical function, sexual function, cognitive function, and vitality. And anything else that you wanted to throw in there if you wanted to do those things, okay? They really felt strongly that long-term studies were not indicated at the time back in 2004, and they wanted to go out of us to go out of our way to assure safety, because again, this is a short-term efficacy study. So the testosterone trials were then born, and I'm going to tell you about what they were and what the results are in the second half of this particular lecture, okay? The more recently published work. So what were the testosterone trials, the T trials, that occurred in the last 10 years or so? Double-blind controlled trials of testosterone versus placebo, 1-year exposure, short-term exposure, okay? Balancing was done by minimization. So it wasn't a randomized trial, but it was done by a way that was appropriate for the particular type of study that we were doing, by a priori setting balancing factors so that groups would be more balanced initially, as opposed to stratification or for pure randomization. 790 men were studied that were over the age of 65. And in order to qualify for the testosterone trials, you had to have a clinical syndrome. You had to have some symptoms and signs of androgen deficiency. And the ones that were the major symptoms and signs that you had to have is you had to have a complaint as well as objective evidence of low libido, low sex drive, difficulty walking or climbing stairs, some functional disability. Okay, or number 3 is to have low energy. We all have that. Okay. Okay. That was not a hard one to actually recruit for. And they also had to have consistently, repeatedly low testosterone levels, at least on 2 occasions less than 275, well below the lower limit of normal for the assay that was used. And they had to have a low risk of prostate cancer. So the major trials, there were actually 7 trials rolled into one, a very efficient way to do 7 separate studies. Rather than funding 7 separate grants to do 7 separate studies, this was funding a large study that was coordinated to actually look at 7 different outcomes related to hypogonadism in a population. And 1 coordinating center, one recruitment strategy, all of the things, the advantages of having this kind of a design, I think are pretty apparent. It was a tour de force only in that it really required all of us to work quite hard in order to actually accomplish this. And I'll show you what we accomplished. The main trials were the sexual function trial, the physical function trial, and the vitality trial. So again, that's the reason why and you could qualify for 1, or you could qualify for all 3, or 2, and depending on what you wanted to do. In addition to the main trial, there were 4 other trials that were more recently reported: cognitive function, bone, anemia, and cardiovascular. So I'll spend some time about the results of these. I think the most requests for what I wanted to talk about, what people wanted me to talk about were the results, because who wants to read 5 papers, right? I mean, you want to know what the bottom line was. So I'll tell you what they were. Now, the testosterone gel that was used, the other thing that tried to deal with the limitations of the previous studies that I had actually told you about, is that it actually titrated testosterone levels, testosterone gel level dosages, to meet a certain goal of achieving testosterone levels within the normal range of a young individual. Okay. At the same time, in order to maintain the blinding so that you didn't know you were on testosterone, people in the placebo group that received placebo gel also had their dosage adjusted. And it was all coordinated in an unblinded coordinating center. None of the investigators, none of the subjects actually knew what they were on and how they were being titrated, and whether they were being titrated with either with placebo or with testosterone. So, screening and recruitment. This is going to be quite dramatic. It took screening over 51,000 people in order to recruit 790 individuals to be enrolled. Okay, that's a 1.5% of the screened population that actually qualified and were enrolled. 65-to-1 screen to enrolled ratio. And what this emphasizes, the second bullet emphasizes, is that in order for individuals to actually qualify because they had too low testosterone levels, below 275, that was only about 14 to 15% of the total population screened. So it's not a common, it's not as common as you might think. If we had just relied on the single testosterone level, we would have had a much easier time recruiting people, but we would have recruited individuals that were probably not, at least biochemically, hypogonadal. Okay, so that's why it was difficult to recruit, besides the fact also that we wanted to recruit people at low risk for prostate cancer. Now, of the 790 men enrolled, 95% completed. So I think we went out of our way to keep people on the study. And in fact, it wasn't actually that difficult to keep people on the study. It's a 1-year exposure, so it's not as bad as a 6-year exposure, which I'll talk about later. So who were these individuals that were studied? So the baseline characteristics of all 790 participants are shown in the next 2 slides. Average age was about 72, so they were older. I think, I consider it older, but not old, because I'm close to where that average is. So I think that's pretty reasonable. So is an older population of males, primarily Caucasian, and we'll get into why that might be. They were obese. Okay, so they were mildly obese. BMI of 31 as an average. Okay, and they had a smattering of cardiovascular risks. Shown here in the top two lines are the risk of all prostate cancer and the risk of high-grade prostate cancer, which was extremely low, and this was on purpose. We used the prostate cancer risk calculator, which is something that was devised by the UT Southwestern group to try to make sure that we recruited individuals that were at low risk for prostate cancer. Okay, again, that was the Institute of Medicine's recommendation, so they were followed quite closely. But what happens as a result of trying to recruit people at low risk for prostate cancer is that you exclude a lot of African Americans because they are at extremely much higher risk for prostate cancer in general, and they are extremely higher risk for high-grade prostate cancer in general. So as a result of the way the design of the study occurred, there were reasonably smaller numbers of African Americans. So you should keep that in mind in terms of generalization of this data. It didn't have much in the way of lower urinary tract symptoms on the International Prostate Symptom Score. They had low testosterone levels. The DISF is the Gerontology Inventory of Sexual Function. The gait speed is in a 6-minute walk, and the facet fatigue score is an energy or fatigue scale. And they had modest compromise as a group of those particular baseline assessments. All these baseline assessments for the primary outcomes here were actually done in everyone. In the normal range. And the answer to the question is yes. And what we see here are the median testosterone, total testosterone levels in the testosterone-treated group in red, and blue, the placebo-treated group. And what you see is testosterone levels were maintained within the 500 to 800 range as an average. But you see a large confidence intervals here. And there's a lot of between individual variability as well as within individual variability. So an individual that has a testosterone level down here may the next time have a testosterone level here or down here again. But by and large, the average testosterone levels achieved were within the normal range, okay, or for younger individuals. Just to point out, everyone got what's called the patient global impression of change. So this is just being asked the question at the end of 12 months, do you feel much better? Do you feel a little better? Do you feel no different? Do you feel a little worse, or do you feel much worse? And what happened, and that gives you an indication of whether or not individuals felt differently at the end of the study. And overall, the people that are on testosterone versus placebo felt that their overall health was better. They felt better in general. Okay, take that for what it's worth. So let's go into the three main trials: the sexual function trial, the physical function trial, and the vitality trial. The sexual function trial really dealt with 459 individuals that complained of low libido and had low libido scores on this inventory, and they had a sexual partner willing to have sexual activity. Okay, and so what happened is that this particular scale, is sexual activity scale, increased in testosterone compared to placebo, and at 12 months it declined a little bit. This is not totally unusual for sexual function to actually go up and then go back down a little bit. The reason for that is unclear, okay, so I can't give you an indication of why that might have happened, but overall, sexual activity based on this particular diary actually improved over the course of 12 months. The same for libido, change in the Gerontology scale, libido increased and then declined just a little bit at the end. And at the end of the day, the global impression of change was that people on testosterone felt much better or a little better in terms of sexual desire. In terms of erections, erectile function, testosterone also improved erectile function versus placebo. This was somewhat unexpected, since erections are thought mostly to be a more vascular event than a testosterone-mediated event. But in fact, erectile function did improve. Now, the degree of improvement here is much less than what you get with Viagra or Cialis or any of the PD5 inhibitors, right? So that I think the degree is much less than you would expect from a medication that has been approved for erectile dysfunction. Okay, so you keep that in mind. In contrast to the sexual function improvements, the physical function trial in individuals that complained of either difficulty walking or climbing stairs and had a gait speed of less than 1.2 meters per second. So that was the entrance criteria. The 387 individuals that were treated with either testosterone or placebo, there was really no difference in the increase in walking distance greater than 50 meters in a 6-minute walk. Okay, so again, this is these are the proportion of individuals that achieve this particular goal, and it was no difference in testosterone versus placebo. On the other hand, if you considered all men in the trial that underwent a 6-minute walk, all 790 individuals, there was a significant small, I would underline, but significant increase in walking distance, or the proportion of individuals able to walk greater than or equal to 50 meters in a 6-minute walk, okay? So that, in fact, there was a signal there in terms of all individuals. And in fact, when you ask the global impression of change, most everybody felt, not most everybody, more individuals on testosterone treatment felt like they were much better or a little bit better in terms of their walking ability compared to the placebo group. Okay. So what about the vitality? Vitality group had complained of low energy and had low energy on an objective scale, the facet fatigue score. And what you see here is the value of having a placebo group, okay, is that both the placebo as well as the testosterone group in fact improved in their energy. And this is like, you know, in the old days when we used to give testosterone, you ask them how they're doing and their batting averages improved, you know, like by 50 points, but they were receiving placebo. So there's a tremendous amount of placebo effect that comes into play here that causes an increase in even in individuals that receive placebo. So there was no improvement in vitality or energy. Although at the global impression of change suggested that testosterone, their energy level was much better or a little better compared to placebo. What did happen, however, in the vitality group is that we also measured as secondary outcomes other things like mood. Specifically, positive moods improved in testosterone versus placebo. Okay? Negative moods decreased in the testosterone-treated group relative to placebo, again, significant. And if you ask about depressive symptoms or depression symptoms using the PD, actually, is this depression? Yes, the PHQ-9, yes, using the PHQ-9 instrument that many of you are familiar with, testosterone decreased depression scores versus placebo. So there was an effect, albeit small. Again, the magnitude of the effect on sexual function was, effect size was thought to be moderate. The effects on mood and walking ability and depression scores were thought to be small. So what were the adverse consequences that occurred? 2 a priori levels were set as being an adverse event. That is a PSA level over greater than or equal to 1 during the study. More people on testosterone achieved that level, and more people achieved hemoglobin levels, erythrocytosis, hemoglobin levels greater than or equal to 17.5 in the testosterone group versus the placebo group. No differences in prostate cancer, in fact only 1 prostate cancer. No differences in cardiovascular events, but albeit this is not a safety study, and so in fact the small numbers of actual adverse events. So those were the studies that were published in the New England Journal a year ago. In the last year in JAMA 2 and JAMA 2 and JAMA Internal Medicine, the rest of the trials, the 4 remaining trials of the testosterone trials were published. I'll talk about each one of them in succession. The first one I wanted to talk about is the cognitive function trial. And in this trial, individuals within this 790 cohort that qualified or that had characteristics of what's called age-associated memory impairment, AAMI. That is, they had a subjective complaint of a memory problem, and they had performance on a memory test that was appropriate for their age, but much less than their younger population. So their T-scores for performance on cognitive function trial tests or memory tests was less than they were when they were young. Okay, so this is the normal age-related decline in cognitive function that we all feel. Not all of you. Some of you are young, but that aside, we all feel a little bit less, maybe having a little bit less memory or difficulty with memory. So these are the individuals that were studied, and they had modest degrees of paragraph recall or verbal memory, as well as visual memory impairment in conjunction with symptoms of memory impairment relative to when they were in high school. This was a negative study in terms of the major outcomes that were looked at. The primary outcome was verbal memory, and the secondary outcomes, visual memory, spatial ability, and executive function, all demonstrated no difference between testosterone treatment and placebo treatment. So I think this is important to recognize that even though there are small studies that suggest, in fact, we did some of these, that suggested improvements in memory or various cognitive functions. In fact, when a large number were done with the design that I just told you about, in fact, there weren't improvements in memory by and large. The one thing that did change, I think that may or may not be significant, is that if we considered all men in the trials, that received, all of the men actually received all of these instruments to try to test for these particular cognitive functions. If you considered all 790 individuals that were actually in the testosterone trials and you looked at executive function, there was a significant improvement in executive function. There may have been a trend here actually in the trial anyway, even though it wasn't significant in the cognitive function group. It wasn't all men. Whether that's significant or not, I can't really comment on. It's a small improvement, okay? What about the bone trial? And I won't go through the characteristics, only to point out the fact in these last 3 rows here, is that the bone trial was done in a subset of individuals in the main testosterone trials that agreed to have a bone mineral density and that had evaluable vertebrae, lumbar vertebrae. They didn't have surgery, they didn't have hardware, they didn't have a lot of things that would preclude them from having bone densities done. So they weren't selected on the basis of osteoporosis. And in fact, if you look at their bone mineral density T-scores, they were really pretty non-osteoporotic individuals. So you have to keep that in mind, that these were the individuals that were not osteoporotic at baseline. And what we showed here is in terms of change from baseline in spine versus hip and trabecular compartment and peripheral compartment and the whole spine versus trabecular, peripheral, and whole in the hip, is that by and large bone mineral density using a volumetric CT methodology. So it actually isn't the DEXA scanning. We did DEXA scanning, but this is a better way to assess vertebral bone mineral density because it basically takes out of the equation aortic calcification or osteophytosis in vertebrae from degenerative disc disease and degenerative joint disease. So bone mineral density improved more in the trabecular compartment of the spine, more in the spine than in the hip in general, but more in the trabecular compartment than in the peripheral compartment in the spine. As well, because this was done with a volumetric determination, CT determination, we could estimate bone strength, okay? And this estimated bone strength also increased more in the spine than in the hip and more in the trabecular bone than in the peripheral bone. This is a a computerized virtual stress model that's used a lot in architecture to see what the strength of a building would be to withstand certain forces. Okay, so this is a simple way of thinking about it. And so with that virtual kind of estimate, bone strength improved in these individuals treated with testosterone versus placebo in the gray bars. The anemia trial. So the anemia trial really set out to really look at the small number of individuals that was called by our hematology colleagues in the steering committee as the unexplained anemia of the elderly. Now, that was a new term for me. I've been in medicine for a long time, but it turns out that that is a term that has been used in the old days that Clem Finch, I guess the Finch lecture is next week, right? That Clem Finch and John Adamson taught me as being hypoproliferative anemia, normocytic normochromic anemia, and one of the causes of that is low testosterone or hypogonadism or hypothyroidism or hypoadrenalism, the variety of other things that cause that, right? That being said, we specifically looked at people that had unexplained anemia in the testosterone trial group, and that was a relatively small number. They had hemoglobin levels around 11 or 12, or around 12, and they had testosterone levels that were by and large lower than individuals that were not anemic. The vast majority of individuals in the testosterone trials were not anemic, but they were also treated with placebo and testosterone. And there were also individuals that had anemia of known cause, iron deficiency, megaloblastic, sideroblastic anemia, a variety of anemias that were thought to be related to a certain etiology. So there were actually three groups, but the main group that we were interested in is the group that had unexplained anemia of the elderly. And what you see here, again, percent change in hemoglobin greater than or equal to 1, or the absolute change in hemoglobin versus baseline, shown in the testosterone-treated group in the black, and in the orange, the placebo-treated group, in unexplained anemia. Okay, and in these individuals, testosterone treatment increased the percentage of individuals that improved their hemoglobin by greater than 1, greater than or equal to 1, and it also increased the absolute amount of hemoglobin versus baseline compared to placebo. The same occurred in anemia of known causes. Okay, so anemia of known causes also had improvements in their hemoglobin, both absolute as well as percentage, and the same for non-anemic individuals. So what does that tell us? That means that testosterone has an effect on hemoglobin. Well, we knew that. Okay, we knew that before. It does tell us, however, that in fact it is a cause, likely a cause or a contributor, maybe not a cause, but a contributor to anemia of older individuals, whether it's related to low testosterone only or whether it's just in general related to other factors related to age. But I think that is an effect. It's a moderate effect and it's a significant effect of testosterone on hemoglobin. All right, finishing up testosterone trials, the cardiovascular trial, probably the most contentious trial, and because it actually turned out to be somewhat concerning. So the people that were studied were individuals that were at moderate risk for heart disease. Their coronary artery calcium scores greater than 300, the percent of those were about 40 to 60%. It looked a little differently here. Again, a relatively small number of individuals. But what was found is that the primary outcome was non-calcified plaque volume increased more in the testosterone group versus the placebo group shown here. But the problem was that if you look at the baseline plaque volume in the groups, they were different. This least square mean value is the adjusted value for the baseline. So even though the adjusted values were still significantly greater in the testosterone group, you have to keep in mind that these groups were different at the baseline. They actually had, the control group actually had much less or much more plaque than the testosterone group. And so when you look at the increase, in fact, the increase in the testosterone group doesn't actually even get close to the placebo group in terms of the actual absolute amount of non-calcified plaque. So again, the meaning of this non-calcified plaque, is not clear. It's concerning only in that it's exactly the opposite of what we expected to see, is that we actually expected, hypothesis-wise, to see a decrease in plaque volume, which has been demonstrated by other folks in smaller studies. So what do the testosterone studies tell us? It told us that there were moderate improvements in sexual function, no change in vitality, but small improvements in mood, decrease in depression, no change in walking ability in people that complained of difficulty walking, but an increase in walking, a small increase in walking in all men, no change in cognitive function, an increase in bone density and estimated bone strength, an increase in hemoglobin both in anemic and non-anemic people, and concerning an increase in non-calcified coronary plaque. Now, there was an increase also in individuals that achieved a higher hemoglobin level and a PSA greater than 1, but again, no increase in cardiovascular prostate adverse events. What doesn't, or what don't the testosterone trials tell us? They don't tell us what happens when individuals are younger or that have more severe organic causes of hypothalamic pituitary pathology, testicular pathology. They don't tell us what the long-term benefits and risks are, which all clinicians are really interested in, and particularly the cardiovascular risk as well as the prostate cancer risk. And the cardiovascular risk has been a particular interest to the FDA, who really mandated the companies that make testosterone formulations to actually do a safety study of testosterone treatment in older individuals for cardiovascular risk. And so that's what has happened this year. Starting this year, there's the Traverse study that is starting up, randomized double-blind placebo-controlled trial, multi-center, 6,000 men between the ages of 45 to 80 that have pre-existing cardiovascular risk or pre-existing cardiovascular disease. So they're higher risk individuals. And the primary outcome is to look for non-fatal MI, non-fatal stroke, and cardiovascular mortality, or what's called MACE, major adverse clinical cardiovascular events, or something like that. And the secondary outcomes have to do to a large extent with composite outcomes and high-grade prostate cancer, but there's efficacy that's also built into it. This is very similar to the ESTEEM trial that I told you about 18 years ago, and it's just too bad that we don't have that data. If we had actually got approved and funded to do that, we would actually have some data to actually practice medicine with. But it'll be another 10 years probably before we get done with this study, and by that time, you'll have other people doing this and talking about it, and hopefully you'll have some more information from which to practice. So the take-home points are: diagnose hypogonadism with manifestations and repeatedly low testosterone. Keep in mind the assay variability and the biological variability, and the fact that testosterone levels are suppressed with illness and a variety of medications that may be treatable without testosterone, and that older men do derive benefit with testosterone treatment, particularly in terms of sexual function, bone density, hemoglobin, and maybe slight improvements in mood and depression scores, and walking, but no changes in energy, cognitive function, and a concerning effect on non-calcified coronary. So with that, I'll stop and thank individuals at the VA that helped with the testosterone trials, as well as my colleagues, Dr. Page, Annawalt, Amory, and our fearless leader, Dr. Bremner, at the University of Washington, for their support. Thank you.